Okay, so today we're excited to have Dr. Chenyang Liu from Washington University, St. Louis. So Dr. Liu is a fellow of IEEE and ACM. So he's the founding director of the AI for Health Institute, and his research focuses on the developing machine learning model to predict the health outcome using the multimodal data, advancing both the precision medicine and the public health. So please join me to welcome Dr. Liu. Dr. Liu.
Okay. All right, it's great to be here. So I'll talk about the AI for health with wearables. This is working. Right, you may have heard that AI is becoming this powerful tool for healthcare. Right, so if you work on AI, right, it's a great opportunity to make real impact on human lives. Right, using AI and data, right, you can phenotype complex diseases and population health. You can predict health outcomes, the risk factors associated with those outcomes, and patients' individual response to different treatments. And you can then ultimately use this to guide clinical decisions and public health policies. And with Gen AI, there's a lot of interest in streamlining healthcare processes and make our healthcare and physicians more efficient. Right? The emergence of AI for health is really enabled by two concurrent trends. Right? One, of course, is this rapid advance in AI technologies, but the other is really emergence of abundance of data, right, from the healthcare and public health domain, right? Most hospitals have electronic health records with abundant data for every patient, their genomics, clinical notes written by physicians, and numerous imaging modalities. In public health, there's public health record, surveys, social determinants of health as well. So the convergence of AI and this abundant data really is driving and transforming healthcare at this moment. And I also say a bit about why it's so important, right, to do interdisciplinary research on AI for health. Right? This is, we are observing this gap between AI and health right now. Right? On one hand, in healthcare domain, right, you have our physicians and the trainees, right? They have all the health expertise and domain knowledge, but they are really, fumbling around, right, using off-the-shelf AI techniques, the basic ones, and try to, work with their data and support their healthcare. Sometimes these simple techniques work. Oftentimes they do not, because the data is too complicated and the problem is too hard in healthcare. And on the other hand, in engineering, computer science, right, of course, AI is this exploding field where new techniques are being developed on a monthly basis and daily basis. But unfortunately, very few of these truly advanced AI have been applied, right, to healthcare, right, in the front lines. Right? So we are missing a huge opportunity to make a difference with AI. But to do that, you'll need this close integrations with AI and healthcare. And working together will solve significant health problems with advanced AI. So in the Institute, we work on a wide range of multimodality health data, but today I'll mostly talk about wearables. Right? Because we are really seeing a significant opportunity for wearables when combined with AI to impact healthcare. Right. So we are sort of in a golden age of wearables. If you go to Target, you pick up a Fitbit wristband or other wearables. Right. So these doesn't cost much and it's commonly available. Right. It measures your step count, heart rate, and sleep stages on a minute-by-minute basis. This is astonishing because I used to work on sensor networks and IoT, and this used to be stuff we worked on, right, 10 years ago, 20 years ago, where how do you measure these modalities in a relatively reliable fashion? Now it's commonplace, right? It's in these $50 devices in every store and on many people's wrists. And this is the future-proof area, right? In a sense, the sensing modalities that just keep growing and becoming better. Of course, many of these versions of the devices now measure oxygen saturation in the blood, skin temperature, breathing rate, heart rate variability, ECG, stress, and the list is growing, right? Every year you see announcements from major companies such as Apple and Google, right, about new modalities. And importantly, and this is truly important, that people are finally willing to wear them, right? So in 2021 alone, right, over 500 million wearables were sold worldwide. This is phenomenal because these devices, for the first time in mankind history, is monitoring patients, right, on a daily basis in their daily lives outside hospitals. Now, I have these collaborators in surgery, right? They say they worry about their patient, right? After a major surgery, they leave the hospital. They wouldn't see them again until 6 months later, if ever, right? Because, right, many of them are from out of state, right? They don't really come back and they don't know what's going on with their patients, right? Now, for the first time ever, there is a readily available device they are willing to wear, and you can have a window into how they are doing, right, outside hospitals in their daily lives. Because these devices, right, monitor our patients in an unobtrusive and longitudinal, manner, right, outside hospitals. And in general, if you want to use this for healthcare, it works as follows, right? So basically, you have, say, a Fitbit wristband or any other wearable devices. The data is uploaded over Bluetooth, right, to the smartphone. So the smartphone, the app, right, upload the data in turn to the Fitbit cloud, right? Then the Fitbit cloud actually provide these nice, web APIs that allow you to pull data, right, of your patients into your own databases, right? So, subject to consent of the patients, of course. Then with the databases, you can run your machine learning models, you can make predictions about clinical outcomes and risk factors, which in turn, right, support clinical decisions and intervention, even while the patients are outside the hospital. So this is basically something we have been doing over a past decade, right? So all these research are enabled by a data collection pipeline that allow us to pull data of our consented patients into our databases, right? These are developed by a group of brilliant undergrads at WashU. And then the machine learning pipeline, right, that basically turn these, right, minute by minute fine-grained data, right, into clinical insights and predictions. And I'll talk more about, right, the machine learning. And once we are leveraging the same infrastructure and pipeline to numerous, right, clinical studies, right? I'll talk about how do you predict surgical complications after pancreatic surgery, right? I'm particularly proud to say, right, this is now, contributing to the standard of care, right, in WashU surgery. In a sense, at this point, at this moment, right, every high-risk patient is given a Fitbit wristband, right, by our surgery department. And we are using our software to monitor their daily activities and well-beings, and use that in this so-called surgical rehabilitation and readiness program to improve their outcomes after surgery. And if you work in healthcare, you will know, right, getting anything into standard of care is quite an undertaking. And we also have projects to work on using Fitbit wristband to predict recovery and outcomes of hip surgery, as well as spine surgery, right? Major types of surgery impacting numerous people. And then I'll also talk about mental health care. Right? So it turns out you can detect depression and anxiety disorders using your Fitbit data. And you can even predict your personalized response to behavioral therapy, right, for your depression and obesity right, using the Fitbit data. And we're also using the same technology to study cognitive functions in youth with diabetes. So this is all sounds really promising, right? But certainly by no means easy, right? So as I mentioned, right, any of the basic wearables measure step count, heart rate, and sleep stages minute by minute. But if you look at this real data from a real patient, right? So the red lines are the heart rate and the blue dots are the step counts, right? You will soon realize, right, these are data that's fairly noisy, right, in the real world, right? And also, right, you're going to lose a lot of data, right? Because this is not patients in a lab going through an MRI scan, right? This is patients just wearing a commercial off-the-shelf device in their daily lives, right? Sometimes they don't wear them properly, sometimes there's motion artifact, sometimes they don't wear them, right? So you end up with a lot of data loss, right? This chart was from this trial of patients undergoing pancreatic surgery. And you see the purple parts are the missing data and the blue parts are the data we collected, right? So every bar here represents an individual patient in that study. As you can see, we lose a significant amount of data. This ends up having real implications on data analysis. So bottom line is we're dealing with fine-grained data, which sounds really great because you get minute-by-minute data. But the problem is no physician or nurses will be staring at this kind of long time series of minute-by-minute data and trying to make decisions about their care, right? They will not be able to predict whether you will have a successful surgery or have depression, right? So you need AI to help you extract much higher level insights from these fine-grained data. At the same time, the data is imperfect, it's noisy, it's incomplete, right? So you have to deal with this kind of data to extract robust insights, right, from this data. So hence today I'll talk about these scientific challenges, right, of dealing with this kind of wearable data for healthcare purposes. The first challenge is how you make reliable predictions of health outcomes, right, despite the imperfections with this data. And second is how you scale your predictive models, right? Because healthcare data has very different scales, right? Sometimes you have these small cohorts of patients in a small clinical study, right? So now your job is to how you get the most robust model with limited data, sort of the small data problem. And then sometimes you have a large population study where your problem is the opposite, where how do you build the most effective deep learning models to maximize the predictive capabilities of your model. And finally, right, in medicine, in healthcare, right, just predicting itself actually doesn't make a difference. It makes a difference only if through your predictions, you impact the actual intervention and treatment so as to change the outcome of the patients. Hence, there's tremendous interest in making personalized prediction of treatment response, right? So that you can support the intervention and treatment that are tailored to an individual patient that's a lot more efficient and effective. So I'm actually going to talk about some of our work to tackle these challenges in the context of 3 real-world clinical studies. First, we'll talk about robust machine learning based on small patient cohort, right, in the context of predicting complications after pancreatic surgery. Then we'll talk about the opposite end of the spectrum, where if you have a larger data set, how do you develop deep learning for large and diverse cohort data, right? Based on, in this particular case, we work on predicting depression and anxiety disorders among users in the community. And finally, we're going to talk about how do you make models to make personalized prediction of treatment response in the context of depression therapy. So I'll talk about the pancreatic surgery study first. And we started this study after one of my talks at the medical school. Then a pancreatic surgeon came to me and said, look, we really have an important prediction problem that we could use your help with Fitbit and AI. Right? So this is because pancreatic surgery is an extremely risky surgery with about 40% complication rate after surgery. But at the same time, this is the only cure for pancreatic cancer. So he said, that every time we have a patient coming in, we have this difficult decision and conversation, which is, should this patient undergo surgery or not? Because if you have a successful surgery, of course, that's great, right, for someone with pancreatic cancer. On the other hand, if you have a surgery with severe complications, it actually makes everything even worse. It's going to make life quality, it's going to make lifespan all worse, after the surgery. So then it boils down to the question, does this patient belong to the 60% who is going to have a successful surgery or the other 40%? And Dr. Hamill said, we have very little information to go by, right, in the clinics and as surgeons. Right? So it's a difficult decision for everybody, for the surgeon, for the patient, for their families. Right? It would be great if we could make predictions about the risk level of a patient developing severe complications after surgery before the surgery occurred. So we end up developing the study where, when the patient comes in to see the surgeon for surgery planning, that usually happens a month before surgery. We give the patient a Fitbit wristband. We collect the data from the patient for about 30 days. Then combined with their outcome, right, in this clinical study, we build machine learning models, right, to predict their probability of developing severe complications after the pancreatic surgery based on data collected before the surgery occurred, right? So this can, right, be important source of information to support the decision, right, about whether this patient should go ahead and with surgery. It also supports decisions about intervention, in a sense, if a patient has too high a risk, if they go for surgery at the moment, they get enrolled into the rehabilitation program, as I mentioned, then they get nutrition, they get exercise, programs, right, to improve, right, their likelihood of a successful surgery than later, right? Of course, we are talking about patients with pancreatic cancer, right, that's developing. So it's very important to get that prediction right. That's why you need a reliable prediction. Hence, our goal is to predict post-operative complications with pre-operative data. This includes the wearable data collected with Fitbit wristband, as well as the typical clinical characteristics of the patient from the medical record. At the time of study, right, these are 61 patients undergoing pancreatic surgery, and right, 25 of them, or 41%, indeed experienced complications after surgery. And in terms of machine learning approach, right, as I mentioned, right, this is the small end of the spectrum in terms of sample size, where clearly you cannot do deep learning models, right, with many parameters because that would overfit quickly. So what you end up doing is to extract features from these minute-by-minute wearable data and then feed these features into shallow machine learning models, right? Now, the scientific question boils down to what features, right? And how do we extract reliable features from these messy and fine-grained data? And then we combine the wearable data with the clinical characteristics, right, as inputs to the machine learning model. So this is a feature engineering pipeline developed by my wonderful doctoral student, Jingwen Zhang, to extract features from these wearable data. Right? You take step count, heart rate, and sleep stages. Right? First, it's a two-stage process. First, we do daily feature extraction. That basically means take 1 day worth of time series and then extract features based on that day. Right? So we get a set of daily features for every day of this patient's data. Then we combine the daily features, right, now become multiple time series of daily features, and then extract further, right, high-level features from the daily features. So then these wearable features combined with the clinical characteristics, right, got fed into the machine learning model to make the predictions. So how does this work, right? So in terms of from the raw time series to daily features, one thing you could also always do is to get a bunch of statistical features, right? Maximum skewness, right? First order statistics, sometimes second order statistics about the time series. But then you can also get semantic features, right? Such as, so these are features people have clues that potentially matter, right? Such as, daily steps, sedentary time, right? As well as, awake count, right? Data features about your sleep quality. So one thing that's important, right, is, recall, one of the big challenge here is you lose a lot of data, right? When you lose a lot of data, it's really important to standardize for your missing data, right? In a sense, for example, if I use daily sedentary time, these are basically total amount of time where there was no step, right? So you're stationary, right? So this is widely known, right, to be associated with many medical conditions. But there is a big difference between if you observe this patient had 2 hours of sedentary time out of 6 hours of monitored time versus 2 hours of sedentary time out of 10 hours of monitored time, right? So that's why you have to standardize it, right, in order to account for different missingness or yield of the data. So you take sedentary time divided by the total number of samples collected, right, in that day. Then you would get a standardized measure of sedentary time, right? This turns out to be small technique, but really useful. And then you turn daily features into high-level features, right? So if you look at, right, this chart, right, it basically shows a particular heart rate feature and over the 30-day time period. If you look at this time series, it's pretty messy, right? It's difficult to make any sense out of this, messy daily feature time series. So the first thing you need to do is to denoise it. It turns out, right, with any standard signal processing techniques would be helpful here. In particular, we apply singular spectrum analysis, right? So that basically come up with the trend line for this messy time series. And then SSA is also good at imputation of missing daily features. For example, if you hide away some of these daily features, right, in this data, and the SSA can also impute, right, the missing daily features as well. So all of a sudden, right, you have a denoised and complete daily time series from which you can have, different statistical measures as inputs, right, to the machine learning models. So how well did this work, right? So these are, of course, the performance results, right, in terms of predictive performance, right, comparing the machine learning techniques against standard surgical risk calculators, right? I want you to pay attention to the NSQIP risk calculator score. This is the standard surgical risk calculator that's provided by the American College of Surgeons, right? This is a surgical risk calculator that's used by almost all hospitals for their surgery patients. And you look at the bottom line, right, in this table, that's a machine learning model combining the clinical characteristics and the wearable data. And what you can see, if I want you to look at the sensitivity and specificity, right? So of course we tune the model so that they have the same specificity. Basically, the machine learning model tripled the sensitivity at the same level of false positive rate. That means the machine learning model is capturing 3 times as many patients who will end up developing complications after surgery, right? Significant performance difference with potential implications on surgical care. Another interesting thing to look at is we actually built 3 machine learning models, right? The top one among the 3 is machine learning model based on just the standard clinical characteristics. The second is based on wearable data alone, and the bottom one is combining both modalities of data. And right, it's good to see that the combined model actually give you the best predictive performance. This is good to know because that basically tells us that the traditional clinical data, the static data, and the wearable data are complementary to each other. This in a way is not surprising, right? Because the clinical data represent sort of standard static properties, characteristics of the patient, right? Versus wearable data represent their dynamic sort of behavioral characteristics, right, in their daily lives. So just to quickly summarize, we have shown that it's possible to extract reliable, high-level features from these very fine-grained wearable data in a hierarchical manner. And it's possible to extract these robust features despite the noisiness and incompleteness, right, of the wearable data, right, with appropriate standardization and denoising techniques. Now, I'm going to switch gears and talk about the opposite end of the spectrum, right, in terms of sample size, right? This time we're going to deal with depression and from users in the community. We have a mental health crisis, right? According to WHO, 280 million people have depression. Importantly, over 50% of them are either not recognized or treated. We have a severe underdiagnosis problem. This is not surprising because people generally do not want to see a psychiatrist until it's too late, right? And in fact, right, so I was talking to a depression prevention expert at Brown University, right? So he told me that at the National Depression Prevention Board, they study all the studies, right, that have been done about depression prevention. Almost every single study reported about 10% effective rate. That's very disappointing. And the national committee wondered, why 10%? Why so moderate performance, right? They came down to the conclusion that it's not necessarily because the depression prevention programs and protocols themselves are not effective. It's more likely because they don't know who and when to apply the depression prevention protocols to. By the time they find a patient with potential depression, it's too late, oftentimes, right? The depression has progressed to a stage where depression prevention protocols would no longer be useful or effective, right? So, and these researchers get really excited about this technology I'm going to tell you about because that allows them to capture patients just as they were about to develop depression, and hence perform the depression prevention in a just-in-time manner. So hence we have this, crazy idea of detecting depression, right, using wearable devices such as Fitbit wristband. But if you think this would be great because this is non-obtrusive, right, and you don't need to do anything, you don't need to go and see a psychiatrist, right? So at least for the screening, and also this is actually not crazy if you think about it, because if you think about what these cheapest wristband measure, they measure step count, which is activity, sedentary time, right? This is known in the literature to be strongly associated with mental health, such as depression. Heart rate patterns are known to be strongly associated with mental health states. And sleep patterns, right, are very strongly associated with mental health as well. So it shouldn't actually be crazy or surprising to think you can detect depression based on these measurements. So hence, right, however, right, so hence it's also not surprising that people have been trying to do this, right? But unfortunately, if you look at the literature, right, in terms of trying to detect depression using mobile health technologies, it has largely suffered from small cohorts and also with limited diversity, right? So there are studies that's published with fairly small sample size, as shown here. Some of the studies, measure college students, which is a very big problem, but college student does not represent the broader population in the community. And then there's the largest study we saw, right, published at MPJ Digital Medicine, had about 1,000 healthy subjects, right? Not people with depression diagnosis. And in terms of machine learning approaches, right, because you have smaller sample size, you leverage shallow models with feature engineering, kind of what I was talking about for the pancreatic, right, surgery study that we did. And if you use deep learning models, it tends to overfit rather quickly. And bottom line is these small data sets limit the rigor and generality of these results. And fortunately, we're at a stage where we can get a much larger sample size for wearable studies. The answer lies in the NIH All of Us program. This is the largest study that NIH sponsored in history with the ultimate goal of acquiring data from 1 million people, right, along with all their clinical data and genetic data, and sometimes wearables, right, so that we could provide a common data set to study many research, right, for personalized medicine. And by the time we look at the study is still ongoing, it's still in its early stages, but by the time we look at this data set, right, we found almost 9,000 participants who contributed their Fitbit data to the All of Us program. Of course, they also contributed their electronic health records. Based on the records, we found over 1,000 of them with depression or anxiety disorder diagnosis. And now, all of a sudden, you have a data set, right, with decent sample size, and also importantly, diversity. If you look at these graphics, right, so in terms of age, right, so these are participants with age ranging from 18-year-old to in their 80s. Very broad, right, population range. In terms of different education levels, we look at a variety of standard measures. It's by and large, a relatively diverse, right, data set and population. And now, basically, you can combine the wearable data with the mental health diagnosis, which provide you the labels, right? Now, it's possible to develop a machine learning model to detect depression and anxiety disorders. So basically what we end up doing is to have our psychiatrists look over the electronic health records and identify 20 depression and anxiety diagnoses. So a participant is considered a positive sample if they have any of those diagnoses. And in terms of input features, we look at wearable data in a 60-day window. And for each day, we get 10 daily features of step count and heart rate. If you're really careful and sharp, you might notice there's no sleep. This is for privacy concerns for those of you who work on privacy, right? So because NIH is doing this large study, they're so careful about privacy, they do not allow researchers from looking at the sleep data, right? But it turns out just based on the step count and heart rate, it turns out you can do a pretty good job detecting depression. With sleep, you probably can do a lot better. And we also look at their fairly standard static characteristics, right, of these participants. So the idea is to look at the 60-day window of wearable data, predict depression and anxiety disorders. So I won't talk too much about the deep learning model because you have a decent sample size. Now we're actually doing these transformer-based deep learning models in order to detect depression with a performance of AOROC of 0.717, right, for a fairly diverse population. What I do want to spend some time talking about is model explanation, right? So, in healthcare, right, model explanation is incredibly important because in healthcare, because it's safety, it's humans' health and lives at stake, right? No one is going to listen to an AI model unless you can explain it well, right? So, and also it's particularly true when you do complex deep learning models with transformers. You say, okay, look at these data. I can detect depression of someone, very sensitive detections, right? So you better have trust, right, in this model. So one thing we did, we say, okay, let's do model interpretation. Let's see, at least at the population level, what are the variables that the deep learning model was looking at? The results was really inspiring, right? In the sense that if you look at to your left, right, these are the most important variables driving the predictions from the wearable device. What is the most important variable? Total steps. That's the number of steps you take per day. Don't want depression? Walk more, right? So importantly, this is entirely consistent with mental health literature over decades. Right? People have found that step count is associated with depression for a very long time, right? And if you look at to your right, these are the static characteristics, right? So the important characteristics are things, right? A female is more likely to be diagnosed for depression. So this is, by the way, something that's still controversial because it's not clear whether it's a bias issue where female tends to be diagnosed with depression or there's actually true, right? So, but then frequent smoker, right, has a higher chance, right, of developing, being detected, right, depression as well by the deep learning model. Don't want depression? Quit smoking, right? So, but again, this is entirely consistent with the literature, right? And this is reassuring, right? Because it basically said, despite all these complexities of the transformer models, it ended up discovering the same kind of risk factors as traditional mental health literature, right? At the same time, it can do so much better, right? And because it can make personalized detections, right, about depression and anxiety disorder just based on your Fitbit data, right? So this can be really important, right, for depression screening, for example, right? You would have, AI, looking at, right, unobtrusively looking at your Fitbit data and detecting elevated risk for depression, right? Going back to my earlier story about working with depression preventionists, right? So that can allow you to, treat, right, depression at a much earlier stage and hence more effectively, right? So just to summarize, right, mental health disorders are prevalent but significantly underdiagnosed, right? So leveraging this large and diverse cohort from all of us, we developed WearNet, which is the deep model for detecting mental health disorders with wearables. And this provides the entirely new unobtrusive pathway for screening for depression and anxiety disorders. So now, as I mentioned, right, so in healthcare, right, it's never enough to just monitoring and predicting, right? You actually have to impact intervention, treatment, right? So this is one we are going to talk about, personalized prediction about the patient's response to therapy, right? If you think about the world of medicine, right, it's largely driven by randomized controlled trials, right? So this is a randomized controlled trial of behavioral therapy for depression that we worked with, right? So this is typical RCT, right, where you randomize over 100 patients into the treatment group or intervention group and the control group, right? The intervention group, right, undergo this particular intervention. The control group do not, right? In the end of the study, you look at, right, the outcome in this case is depression remission, right, in 6 months. If you compare the intervention group and control, traditionally what we do for all randomized trials is statistical analysis, right? Statistical analysis basically establish the statistical power that says, okay, at the population level, statistically, the intervention group get better outcomes than the control group. And hence, statistically, I declare, right, this intervention to be effective, right? That's how medicine works, right, for all the drugs and therapies and so forth. However, what this doesn't tell you is whether this therapy will be effective for you as an individual, right? This is particularly true for things like behavioral therapy for depression, which is very hit and miss, right? Even though statistically, on the margins, right, you get better, you're more likely at the population level to get a better outcome with the therapy. That says nothing about you as an individual. And it's very, very frustrating for an individual to undergo 6 months of behavioral therapy that costs a lot of money and time, only to be told, oops, right, this one doesn't work for you, right? So hence, we look at this to say, we realize if you take the same data that's already collected through the RCT, and you build machine learning models, you can make personalized prediction of whether you as an individual will be responsive to the therapy. More specifically in this case, right, we take the clinical characteristics, right, the baseline data of this person, and then we take first 2 months of the Fitbit data. If you have been undergoing the behavioral therapy, the model will predict, right, so whether you are likely to get a depression remission if you continue on with the therapy for 4 more months, right? If the model says, no, you're unlikely to get a depression remission, maybe it's time to consider alternative interventions, right? And vice versa, if you're not currently under therapy and you're in the control, right? So, and then 2 months later, we look at the data, the machine learning says, you're unlikely to get remission, right? Just by doing nothing, right? Some people do get better without doing anything. But then maybe you should start therapy, right? So this is the idea of making the therapy a lot more targeted and effective for you, right? Hence more precise, right? Again, I won't dive too much into the details of this work, but basically this is a multitask learning model that my student Ruixuan Dai did, right? So, so the idea is you struggle with a small sample size, hence it's better off to build a multitask learning model for the entire cohorts, including both the intervention group and the control group. Then it boils down to you have to learn the commonality, right, from both group of patients. This makes sense, right? Because by design, all randomized trials at the baseline, at the beginning of the study, all the patients are statistically similar. That's a basic requirement of any RCT, right? Hence, the idea is we want to have this common layer in the multitask learning architecture to learn the shared characteristics, right, of the control group patients and the intervention patients. And then we have the separate layers, right? So the one for the intervention group and the other for the control group. And these layers look at the wearable data, right? The reason this is because as the wearable data come in, that's when the therapy is ongoing, right, for the intervention group, right? The wearable data would be reflecting the impacts of the therapy, right? So that's why you want separate layers. This is to capture the differences, right, between the control group and the intervention group. All right, so just to summarize, right, these 3 studies, right, we have seen promising results where you can make reliable predictions of health outcomes. You can scale these predictive models based on the sample size that you have, and you can predict treatment response. There's a lot of next steps, right? Certainly, we need to scale up clinical studies, right? So, for example, for the pancreatic surgery, now we are looking at all the patient data from the standard of care in the prehabilitation program I was talking about, right? Because now all the high-risk patients wear Fitbit. Now we are looking at instead of 60 people, we're looking at 600 people, right? So, and in general, we're doing a lot of these larger, so multi-center studies, right, to scale up these, these results, this data set, and hence the robustness of the results. It ultimately has to support personalized intervention, right, in order for these to make a difference and ultimately translating to clinical practice. I think I have a few more minutes, so I'll actually take the opportunity to talk about a couple projects potentially that beyond wearables. Right? The first one is about, right, remember talking about post-operative risks after surgery. One of the newer projects we did was, how about the clinical notes, right, written by the surgeons before the surgery, right? So can we actually predict whether a patient would develop complications just based on the notes that was written before surgery? This makes sense in the sense that the notes basically capture the observations and insights of the surgeon, right, about this patient, right, along with the typical data about surgical types and procedural details and so on, right? So basically, in this case, we're looking at, right, these large language models. We didn't do GPT, right? So, but rather we did these typical biomedical models, right, such as, clinical bird type of models that are trained on medical literature and clinical data. So first, we are looking at how does pre-trained large language models, right, do, right, in terms of predicting post-operative complications. Second, what if you fine-tune these models, right, to the surgical notes, right? What if you incorporate the labels, right, the actual surgery outcomes, right, into the fine-tuning process? Would you do better? And finally, how about foundation models, right? In the sense that, can you build a single foundation model that's able to predict multiple surgical complications? To a hospital, this is very appealing because instead of maintaining and updating many different models, one per complication, now you have one model that's able to predict, right, multiple complications. So it turns out, right, just the pre-trained sort of clinical language models did pretty well, especially in comparison to traditional NLP, word embeddings, right? In fact, they got 33-point gain, right, in sensitivity at 95 specificity in comparison to traditional NLP embeddings. And if you look at this chart, this basically shows the percentage of increase in sensitivity in comparison to traditional NLP embeddings with, right, the 4 different versions of the large language models, pre-trained, self-supervised fine-tuning, right, to the surgical notes, self-tuning plus semi-supervised to the surgical outcome labels, and the foundation, right? The good news is, turns out the foundation, these are for the 6 different surgical complications, 12, you see that box on the right. The good news is, turns out foundation models did the best, right? They did better than any individual fine-tuned model for specific, right, surgical complications. So this is really good news that shows that scalability, right? You can potentially do one foundation model, right, predicting various, right, surgical complications. So the other thing I want to talk a little bit about, right, is about this big project we are doing on brain malformation called Chiari malformation. So in the interest of time, I'll be really brief, right? In the sense, the idea is it's a heterogeneous condition that many kids suffer from. People need to really understand the more precise subtypes of the same brain malformation. But we are looking at multimodality data, radiographics, clinical family history, and so forth, which end up with 500 variables. Clinicians cannot really tell, right, which subtype this, right, patient may belong to just based on 500 variables. It's just too many for human. So hence, we're doing this clustering analysis based on data from 42 medical centers and end up developing these, identifying 3 different subtypes of the brain malformation, and importantly showing the discovered phenotypes are reproducible in other medical centers as well. And overall, this is based on 42 medical centers. This is an ongoing sort of NIH PO1 project that we have been doing. And these also importantly, according to neurosurgeons we work with, these have real clinical implications, right, with the 3 identified subtypes of Chiari malformation. Right. So toward AI-driven healthcare, right, just to recap, right, for wearables, right, now we have shown that wearables can provide valuable insights, right, in your health. And AI is really important, right, to extract these reliable insights, right, from these imperfect data. From an AI for health standpoint, right, we really want to be able to do, right, personalized predictions, right, that enable targeted interventions. This is what precision medicine is all about, right? But at the same time, we have to make rigorous clinical trials, right, in order to validate these AI models. In a way, AI models are not all that different from a traditional diagnosis or intervention. You have to validate these models with trials, and that require, right, close collaboration between AI experts and clinical researchers, right? This is why at WashU we started the AI for Health Institute, right? The idea of bringing together the AI experts and clinicians, right, to tackle, right, critical health challenges with advanced AI. And at this moment, we have over 100 faculty members from 26 different departments spanning many areas of AI and clinical medicine. If you're interested, check out this website. Thank you.
Okay, so any question? Okay.
Thank you for the wonderful talk. One question about the foundation model evolution. So you developed the foundation model, you trained the model.
Yeah. We took we look at multiple different biomedical large language models, clinical bird, bioclinical bird, you know, various, one of them is based on GPT-2 as well, right? So then we fine-tuned them.
So can you provide more details for the data you are using for the fine-tuning?
Oh yeah, so this is surgical notes from, if I remember correctly, about 60,000 surgeries at BJC Healthcare.
So this data is just like a clinical notes and also
clinical notes written before surgery along with the surgical outcomes. Yeah.
Okay, I see. Where did you get this data?
Oh, this is from BJC Healthcare. That's a WashU medicine healthcare system.
So it's not a public.
Unfortunately, that's beyond my pay grade in releasing these data. Yeah.
Okay, I see. Any other question? Okay.
Thanks for the talk. I just have a quick question about that video. Would you like to go back to the page?
Slide 8?
Yes, slide
okay.
8. Maybe that's the technology that you take seriously.
Okay.
Yeah, so my question is like
This probably not this one, right?
18.
18. Okay. All right.
The technology part of that service.
Well, we can backtrack. This part?
Yeah.
Okay.
This way. So yeah, my question is like, how do you distinguish the noisy data and abnormal data? The time window is pretty tricky. The time window is not easy to find the feature of this time certain data, but at the same time, we may ignore the abnormal data. So how do you handle this situation? This is pretty tricky things.
It is. It is. That is a very good question. Well, I guess these denoising techniques are fundamentally heuristics, right? So I think we are using this, and I actually have a slide that shows this really make a difference. But of course, right, it's probably differs depending on the particular data and medical conditions. But let me show you. This is the results, right? So it basically says with denoising, right? So you'll increase your AROC substantially with denoising, right? This basically says that denoising procedure did more good than bad. But certainly it's a very good question.